Hello, my name is Liz, and this is my research proposal on individualized versus traditional intuitive eating interventions for binge eating recovery. To introduce binge eating disorder, it is a diagnosable disorder in the DSM-5 that therapists use for patients, and the key characteristics of it include a loss of control while eating and eating large amounts of food compared to normal portion sizes, even when not hungry, and there is extreme guilt and shame related to these binge episodes. And these episodes occur one or more times per week for 3 months, with no compensatory behaviors, which include exercise. The current treatment and recovery in the current literature include cognitive behavioral therapy, which is the gold standard, as well as pharmacotherapy and nutrition therapy. Nutrition therapy includes traditional mindful and intuitive eating measures that help improve the relationship of food and clients. And that leads me to my research question. In patients with binge eating disorder, do individualized intuitive eating interventions lead to a lower prevalence of binge eating symptoms compared to traditional intuitive eating interventions? And my hypothesis is that individualized intuitive eating interventions will lead to a lower prevalence and severity of binge eating symptoms versus the traditional measures. With the current literature review, some of the main points that I found was that mindful and intuitive eating does reduce binge eating frequency and severity, but with the short-term interventions that seem to be more observational, they struggled with adherence and scalability to the general population, and the longer-term interventions had improvements in body image, hunger, and satiety regulation, but overall there was an emotional regulation gap because these interventions don't address the bigger issue, which is coping with food, negative emotions with food, and the symptoms are basically the binge eating episodes. Other main points that I found was that a higher baseline intuitive eating associated with lower odds of binge eating at follow-up. And so in my research, I will try to close this gap by having patients in a strata with a baseline intuitive eating and binge eating severity. And there's also psychological comorbidities such as depression and anxiety that can exacerbate binge eating behavior as a way to regulate these negative emotions. And my research study will also close this gap by incorporating strata based off of mild and severe and being present or not. Some of the limitations and solutions, I've already addressed a couple of them, but with some of the studies, there was a short-term focus, mostly observational studies. My study is a longitudinal study with a post-intervention 6-month, 12-month, and 2-year post follow-up to see adherence levels with the individualized intuitive eating. There's also adherence challenges that I went over and overgeneralization. There's also limited causal evidence and these observational studies and methodological issues. These small sample sizes, such as in the Latimore study, that can cause a decrease in the amount of detecting real effects and also increasing the amount of type 2 errors. And also, finally, the psychopathology was under-addressed, and my research will help to close that gap. For the methodology, my research design is an experimental longitudinal study divided into groups by stratified randomization. My groups of strata include BED severity, which I will categorize based off of mild or severe pathology, psychopathology, if it's present or absent, and also antidepressant use. And then these participants, it will create 8 strata, and then these participants will be 18 to 30 years old, both male and female, and they'll have a large race and economic status and education distribution, and there will be 50 people for the intervention and then 50 people for the control group, which is the traditional measure, and that'll equal 100 people total, and that takes into account attrition rates. more intervention details. This would be a 12-week study, which is then administered weekly through 90-minute individual sessions, one-on-one with a specialized eating disorder dietitian, therapist, or clinician. In these sessions, we'll focus on individual characteristics of these patients that they need help on, such as body image work, coping with specific thoughts and emotions that do trigger these binge episodes, and then also providing ways that they can cope with these negative emotions that don't involve food. And then also journaling and having just intuitive and mindful eating practices in general. For the data collection, I will be collecting from 3 different sites. These include the outpatient eating disorder clinics, community counseling centers, and posting on social media, and gathering people through flyers and community web pages. I think this will allow my study to have a broad range of people, from severe clinical diagnosed BED to people who might not even know that they have it and therefore might be willing to be part of the study, and also having differing levels of motivation and levels of change. For demographics, I will collect this throughout the first couple months of my study before it starts. Things such as age, gender identity, ethnicity, BMI, and psychiatric history. And for IRB compliance, I will need a full IRB approval because I'll be working with human subjects, and there is a potential for psychological risk because we are dealing with eating disorder patients. For data collection, I will be assessing BED severity, psychopathology, and baseline intuitive eating. Through all of these measures, they will mostly be through surveys, such as the binge eating scale score, the PHQ-9 depression, and the IES-3 self-report measure of intuitive eating. For analysis, I will be using 2. I will be using the chi-square test of differences for categorical overall data if we have improved versus not improved frequency of binge eating episodes, based off of the beginning and the end of my intervention. And then the ANOVA will also help with continuous measures if the frequency of binge episodes decreased over time. So it basically analyzes the rate of improvement over time, and it can also do it for the different stratum, the 8 different stratum that I have. And this graph right here that I have, it shows these 8 different stratum. And one of these the first one includes people with low, mild binge eating severity, and no psychopathology and no antidepressant use, compared to people who all have all those characteristics in strata 8. And I'm thinking that there's going to be in this graph, about a 67% reduction in the amount of binges per week in strata 1 compared to strata 8, with only a 32% decrease because of these individual characteristics that do impact binge eating recovery and the frequency of them. So to discuss the strengths and limitations of my study, I will anticipate to reject the null hypothesis. So that means that there is a difference between the groups. Individualized interventions do reduce the frequency and severity of BED. My strengths that don't compare to other studies is that it will show adherence through these 6-month, 12-month, and 2-year follow-ups compared to other studies. And then the limitations, some of them, there might be differences in how treatment is introduced based on the dietitian or therapist. And with the longitudinal study, there is a increased risk for attribution rates and increased sampling error, which is type 2 error, where the real effect is missed. And therefore, that would mean that we would basically be, there would be no difference between the 2 interventions when there actually is. And also the self-report bias and confounding variables too. Finally, for future research, I think It will allow for advances in the clinical setting through increased personalized nutrition and psychology treatment models. And also these treatment models can then match these patients and help tailor more resources to the patients who do need them more, such as the more severe BED and ones with more severe psychopathology. And also it can guide clinicians and eating disorder dietitians just in general for the best treatment options, and also have further research questions developed, such as why maybe antidepressant users respond differently to treatment and hunger signals. And these are my sources. And thank you so much for listening to my presentation. Have a nice day.